And clearly this is a very broad topic, and so I'm going to just cover a few areas that I think need some discussion, where there's still some controversy and the need for better understanding. So just very briefly, to start off with the clinical process, we know that this is a disease that has a broad spectrum, from a mild self-limiting disease to a potentially life-threatening disease. Just very briefly again, from a clinical point of view, the most typical signs of acute cholecystitis is abdominal pain. And we know from the Tokyo guidelines, the 2013 version, that the evidence supporting the clinical Murphy sign is not very strong. And we have to rely on investigations. And I think that it's very important that ultrasonography is recognized as the important, or the first sort of screening tool for clinical suspicion of acute cholecystitis. And it has a range of sensitivities and specificities, but as the first screening test, I still think it remains the most important. The Tokyo guidelines, which assists us in making the diagnosis and tries to give us evidence at a much higher level as to how to make the diagnosis, divides the clinical symptoms into three groups. First group are signs of local inflammation, such as the Murphy sign, but also pain, tenderness, and a mass in the right upper quadrant. The second one is systemic signs of inflammation, such as fever, an elevated C-reactive protein, and an elevated white blood cell count. And then we rely predominantly on imaging findings of acute cholecystitis, and I think those are fairly well described. So to have a suspected diagnosis, we need to have one item in A and one item in B, but to have a definitive diagnosis relies on an imaging finding today. Now, I think important for our discussion today is to understand the range of severities of acute cholecystitis, and again, the Tokyo guidelines, updated in 2013, assist us with this. So the grade 3, and I'll start there because I think that this requires the most understanding, but really, as it does with other inflammatory conditions in our area of work, it relies on the presence of organ dysfunction, and those are described using current strategies such as the Marshall score. The grade 2, or the moderate acute cholecystitis, I find this to be an area that is most difficult to understand. So while the white blood cell count and the presence of a mass are easy to understand, I'm not quite sure about the issue of a duration of complaints greater than 72 hours, why that should make it necessarily a moderate form of acute cholecystitis. And then the presence of local inflammation such as gangrene, abscess, hepatic abscess, peritonitis. Again, those usually are what we would find in the severe form of the disease. And grade 1 really is where both of these are excluded. It's a mild form of the disease, and really this is where there's no organ dysfunction, no signs of significant local inflammation, and cholecystectomy is really a safe and low-risk operation. Now, this study for me was quite, or this description for me was quite helpful, because if you look at this table, you can see that they talk about the different grades. I'm not going to talk about this lot, but we have, and I'm not going to talk about notes, but we have these options, which is laparoscopic, open, percutaneous, transpapillary, and transmural drainage. And according to the grade, it defines which procedure is most helpful. And again, I'm not sure about the absence of laparoscopic cholecystectomy in the grade 3, particularly in areas where excellent skills exist. But I do think this helps in general to define what should be the normal surgical option in this disease. We've heard a lot about safe cholecystectomy today already, and I think that the SAGES program really gives us a good basis against which to look at safe cholecystectomy, making sure that the patients benefit from a whole range of issues, but particularly from avoiding the common bile duct injury. So the components that I think apply both in all forms of surgery for cholecystectomy, but specifically in acute cholecystitis, is the critical view of safety, which we've heard a lot about today. And I think the components of the procedure, such as a timeout and getting the opinion of those around the operating table with you, is important. understanding the potential for aberrant anatomy, that always needs to be in your mind. And then a few words in a little while around the liberal use of cholangiography, and we've already heard a significant discussion around that today. And then also being aware when you're approaching difficult areas of the operation, and then to get help when you're in trouble. Now, one of the issues that have come up in these postgraduate courses before is when many of the trainees say, why conversion to open cholecystectomy? It's not something I've ever done, and how can that be safer than a laparoscopic cholecystectomy? And so I think those of us who have had experience in open cholecystectomy need to understand that potentially opening may not be a salvage procedure, and possibly what's necessary is a more experienced colleague rather than necessary open conversion. So the first issue I really want to look at, and where I think we still don't have absolute answers, is the debate around early versus delayed cholecystectomy. In the period or the era of open cholecystectomy, the evidence at that stage supported early cholecystectomy. But as with the development of lap chole, it wasn't quite clear, and particularly in the early phases, it was considered not to be an indication for laparoscopic cholecystectomy. But as I experienced, the technology improved, so we started to ask that question again. And I think that today, for the majority of the evidence, supports early cholecystectomy, and I want to look at some of that evidence. But I think what's not clear to me is certainly what early means. And we heard that as a discussion around the repair of bile duct injuries. What does early mean when it comes to cholecystectomy in acute cholecystectomy setting? So systematic reviews have clearly showed that early laparoscopic cholecystectomy is as safe as delayed cholecystectomy and clearly results in shorter hospital stay. And the areas that we need to consider when we look at this evidence is the duration of the operation, the duration of stay, injuries to the bile ducts, conversion, overall complications, wound infection, which I'm not quite sure I fully understand the implication there, but mortality, and then importantly, cost effectiveness and quality of life is now being considered. So if we look at the studies that talk about this, here's one that started to look, and these are all fairly recent publications, but this looked at patients who presented beyond 72 hours of symptoms. So again, it doesn't make it clear about what to do, as we'll see earlier on, in patients presenting before 72 hours. But in here you can see that most of there was either no significant difference between the two, or where there was significant difference was in about overall morbidity, in some of the other complications, length of operation and length of stay. So it starts to suggest, when we're looking at issues like conversion, there was no difference. The length of stay is clearly in support of and this is in this study, it was post-operative length of stay and not overall length of stay. And so the time here was shorter in the delayed procedure, but readmission rate was higher in the delayed procedure, but not statistically significant. So the whole issue around talking about the delayed cholecystectomy, I guess, needs to reflect on what the consequences of the delayed cholecystectomy. And there have been a fair amount of data that suggests that the longer you wait, the greater the incidence of gallbladder-related symptoms are. And so we have to reflect on what we do against that particular data. The study was a population-based propensity score analysis, and again, it showed that cholecystectomy within 7 days, was similar to the delayed procedure. And the results support the practice of early over delayed. But here again, I remind you, this was within 7 days. And if you look at the various issues, major bile duct injury was slightly lower in the early group than the delayed group. The bile duct injury and death was again slightly lower in the early group. Mortality was better. The length of stay was significantly shorter, and the number of patients requiring open cholecystectomy in both groups, as was the conversion, was fairly similar. Now, I present this study because while it's not published in a great journal, it certainly is a large number of patients in a hospital that I think many of us would find ourselves practicing in. And here again, they looked at patients within 7 days or those greater than a month or longer. Conversion rates were comparable. Operative time was slightly longer in the early group, as we would expect. The intraoperative and postoperative morbidity was comparable. and the length of stay again was shown to be shorter. But what I thought was quite nice in the study was the univariate analysis where they looked at conversion in patients with acute cholecystitis, and they showed that increasing age, presence of comorbidities, previous abdominal surgery, a Murphy sign and low albumin all predicted for conversion in the earlier group. Now, this study has already been shown to you today, and this was the study out of Heidelberg, which was a randomized controlled trial comparing early within 24 hours. And again, this is what makes it difficult for us always to understand what we're comparing, but certainly here in the early group, the morbidity was better and significantly better than those waiting for longer, those who had delayed procedure. But conversion rate and mortality was no different. And as we've seen, I think it's clear that length of stay, total length of stay is certainly higher in the delayed group, and that the cost is significantly higher in the delayed group. So if we're going to do it in 24 hours, then came the question, should we do it immediately on admission? And so should we be doing nighttime laparoscopic cholecystectomies? And this study I thought was quite nice in that it showed that there was an increased risk of conversion if it was done at night. And so I think the suggestion is, while it needs to be done as soon as possible, it probably shouldn't be done during the night. And then to look at the meta-analyses and the systematic reviews on the subject, they've not really given us the answer. The Cochrane review in 2013 suggested that there was no real difference between early and late, but they did show that the studies that supported early, that there was some kind of bias in that group of patients, and that the studies and the data was not as reliable as the others. This meta-analysis published a little bit later, and again suggested that the optimal timing was still debatable. But one of the consistent findings, even in this study, was the length of stay, and that certainly suggests that, and if we look at these forest plots, we can see that the risk when it comes to issues such as wound infection, bile duct injury, bile leakage, and conversion to open surgery and overall complications were not significantly different. So I think that the issue around the when to do it, I guess we should accept that early cholecystectomy is safe, but whether it should be done within a few days or whether it should be done within 24 hours, I think still remains to be determined. Now, one of our concerns with all laparoscopic cholecystectomies is bile duct injury, and how does that affect acute cholecystitis? And it's quite clear that acute cholecystitis is one of those issues that predict, particularly if there have been previous attacks, that will predict a higher incidence of bile duct injuries. So that's not an operation that I think should necessarily be performed by the most junior member of the team. But I remind you that most of bile duct injuries don't have a risk factor. And so it doesn't completely exclude doing a cholecystectomy in the acute setting. So we've heard about doing safe cholecystectomies, and we've looked at how we can prevent it, and clearly the whole issue around the critical view of safety must be taken into consideration. It's really important in patients with acute cholecystitis, and this is not a group of patients that we should be taking a compromised approach to, and that the critical view of safety, as well described in these pictures, should be recognized. In my own experience, it's this part of the operation where you expose the gallbladder plate, or the part of the liver, which is absolutely essential in achieving the critical view of safety. And I think in the difficult cholecystectomy, many of us tend to compromise on that particular component, and I would say to you that's very important. Now, I don't want to go into the whole discussion about routine intraoperative cholangiography. There are those that are for it, who believe it does reduce the incidence, those who, as we've heard, earlier recognition is possible, the injury may be less severe, and if you do it routinely, you're less inclined to misinterpret the cholangiogram. But others who are skeptical say that it doesn't prevent the injury. It occurs sometimes before you've done the cholangiogram, or it may occur after the cholangiogram, and in fact, if you can't read it, you may miss it. So the evidence is quite old, but here's a study that talks about routine versus selective, and in this study, it suggests that routine has better or lower bile duct injuries. But Flume has, I think, made a great contribution to this discussion. And in this study, he looks at patients who do it routinely and patients who do it only occasionally. And this is a difficult table to look at, but what I want to point out for you, if you do it not routinely, if you don't do it routinely, and you do an intraoperative cholangiogram, your incidence of bile duct injury increases. If you do routinely do bile duct on-table cholangiograms and you don't do it, your bile duct injury increases. So I think that the take-home message for me here is that if you do it, continue to do it. If that's the way you were taught and that's how your experience is. But if you want to do it selectively, then we heard earlier today some of the indications for that. And if you're not going to do it ever, then you've got to be very careful with defining your biliary anatomy. And so the critical view of safety becomes really important. So we do know from these studies that, as I've indicated, that while cholecystectomy, acute cholecystitis is a risk factor for bile duct injury, it's also a risk factor for conversion. And this study clearly on its forest plot clearly shows that it has a significant risk for conversion. And the reasons, I think, are quite easy for all of us to understand. It's about the severe inflammation. The Tokyo guidelines, again, suggest in mild cholecystitis, this is not going to happen, but in the more severe forms, you're more likely to convert. Now, I want to talk a little bit about acalculous cholecystitis because it reflects on my next discussion, which will be around cholecystostomy. And this occurs in about 3.4% to 14% of patients with acute cholecystitis. We all know that it's common in the severely or critically ill patient, but there are a group of patients who present out of the community with acalculous cholecystitis. Gangrenous cholecystitis and perforation are more common in this group of patients and often associated with multiple organ dysfunction. And while in patients who present out of the community, the mortality rate is very low, in the critically ill patients, it's not clear whether it's the cholecystitis that kills them or whether it's the general organ dysfunction, resulting in this ischemia, reperfusion, pro-inflammatory situation. So let's look at the role of cholecystostomy in these patients. It's not uncommonly used in these patients, with about 1 in 10 patients requiring a cholecystostomy. And it's very good in resolving the acute cholecystitis. It may not be always a definitive therapy, but most patients who get a percutaneous cholecystostomy, the acute cholecystitis will resolve. In some patients, as I say, it is a definitive procedure, and it's useful for patients who cannot undergo laparoscopic cholecystectomy for one or other reason. But it does have its own adverse events, and in my experience, the dislodgement of the tube at an inappropriate time becomes one of the main problems. But actually, when patients are walking around with this tube, they're often elderly patients and complain about the negative impact it has on their quality of life. The next issue is about when to remove these tubes, and I think that still does, the evidence doesn't give us a clear answer, but some of the guidelines are that when the trachea is matured between 3 to 6 weeks and the acute cholecystitis is resolved, and that the cystic duct is patent, suggesting or confirming the resolution. I'm not sure about how many gallstones is an indication to remove it, but what I am clear about is that if you've got common bile duct stones, removing this tube results in significant problems. So let's look at some of the evidence. This study here, and the evidence is not great. Most of the evidence is cohort studies, but this is a large study and it's over a long period of time, and so I thought it's valuable because it raises some of the issues. The mortality rate is quite low in this group of patients, and about 1 in 10, about 10% are amenable to early laparoscopic cholecystectomy. But in the remainder of the patients, it's where the problems exist. So some of them will be able to go on to elective cholecystectomy. You either reverse the comorbidities, or when the sepsis resolves, they become fitter. But during that period of time, about a quarter of these patients will have a recurrence. But what's interesting is that in almost 50, or just over 50%, this will be definitive treatment. Can we predict the value? And I think really it's about the cholangiogram and showing the filling of the duodenum through the cystic duct that really predicts which patients will improve. When they fail, we have the same range of issues, and this becomes a complex situation when they have recurrence. What do you do then? And again, a similar proportion are going to follow what we've previously described. The last issue around cholecystostomy is how it should be performed. I thought that we'd all move towards transhepatic cholecystostomy, but this study suggested that actually people are still doing transabdominal cholecystostomies, and to my surprise, there was no real difference between the two. I thought that the dislodgement of the tube, the leaking around the cholecystostomy was going to be higher in patients who had direct transabdominal, but the evidence doesn't seem to suggest that, but they do suggest that the transhepatic approach gives more stability to the tube and therefore should be the preferred approach. Now, many of these procedures get done in patients who are old and on anticoagulants, and so I thought it was important just to look at the Society of Interventional Radiology guidelines, which suggest if patients are on aspirin, you can go ahead and you don't need to stop it, particularly if they're at high risk. However, with clopidogrel, they should be delayed. Those with an INR greater than 1.5 should be delayed or given something to improve that situation. And if patients are on both of them, these patients we should avoid. And really, I think that it then talks to the next situation, which is around the role of endoscopic approaches. And where you have those skills in that group of patients, this is probably better. Now, this is a recent patient of mine who presented with a perforated gallbladder. By the time we did this, you could see the stones, but the importance in her is the presence of the common bile duct stones. She's 92 years old. You can see that she's had multiple stents, and still has a thickened gallbladder wall. And in this patient, we've not been able to remove the cholecystostomy, and our thought now is about whether we should approach the common bile duct stone through the liver, and that's a discussion that I'll take up tomorrow. So endoscopic drainage of the gallbladder, which is not something that is easy to do and commonly performed, but certainly we can do it via the ERCP or EUS. And again, if you get drainage of the gallbladder, just like the cholecystostomy, the success in resolving the acute cholecystitis is really excellent. So here are some of the examples or how we do it. Here we can either put a stent into the gallbladder. Sometimes instead of putting the stent into the duodenum, we use a nasobiliary tube, and then we can irrigate and wash out. Or more reasonably, using mucosa-opposing stents, we can do that under US and get drainage of the gallbladder. So it should be considered, I think, that the percutaneous approach should be considered the first step in intervention. And when we look at the randomized controlled trials comparing percutaneous transhepatic drainage with endoscopic gallbladder drainage, it seems to me that there is not all that much difference. But the whole issue is that endoscopic gallbladder drainage can be considered only when the high volume or the expertise exist. So when endoscopic transmural drainage is used as a bridge to subsequent cholecystectomy, it really did well, and it's found to be as effective as the percutaneous group, as I've said. But what's interesting is that the quality of life, pain, and the discomfort with the bag seems to be better in patients who've had endoscopic approach. So also, if you look at the bit of data that's available around comparing the drainage with the nasobiliary tube or the biliary stenting, the meta-analysis suggests that there's very little difference between the two. The last area that's also been discussed a little bit is subtotal cholecystectomy. And I think that the whole question is there a good option between cholecystostomy and cholecystectomy? And does anything less than a complete cholecystectomy result in the need for a second procedure? And I think these are the questions that we've asked ourselves when considering subtotal cholecystectomy. And part of the awareness, according to Stephen Strasberg in the article I'll show you now, he believes that it's an issue related to terminology and that we don't all talk about the same bailout kind of procedures. This procedure was written up first from Cape Town by Blanche and Bornman, who discussed the role of subtotal cholecystostomy. But Strasberg, in the article I just referred to, gives us some insight in how to do this by talking about two different types of cholecystostomy, which is the fenestrating or the reconstituting. So the fenestrating is where you remove part of the gallbladder and you close, as shown here, the cystic duct. And the reconstituting is when you don't remove the whole gallbladder, you leave some of Hartmann's pouch intact, but you close the gallbladder, reconstituting a small degree of the gallbladder. So the concerns was, does this leave a remnant gallbladder that can become symptomatic in the future? And it doesn't seem that there's evidence to support that. And if you do the fenestrating type, does that have a high risk of a biliary fistula? And that seems that if it does occur, it certainly resolves spontaneously over a period of time. And the issue is that this can be done laparoscopically and can be done even by general surgeons who have some laparoscopic training. So here's a video, if I can get it going. Can you start it for me? Anyway, yeah, thank you. So just briefly, this shows you using the harmonic scalpel. I don't show you here that we use a hook diathermy as well. But in fact, you can remove part of the gallbladder. And then, can you move it on for me, please? Move it on. A bit more. Forward. No, just... Okay, anyway, this just shows you that we suture the gallbladder, reconstituting the gallbladder in this patient. And so while it is a slightly more challenging operation, with advanced laparoscopic skills, this becomes easy to do. So when it comes to the technical approach in these patients, the critical view of safety is absolutely essential. If you can use a fundus first or infundibulum approach first, using your laparoscopic skills, that's sometimes of value, but in these difficult gallbladders, it still leaves you with a challenging dissection into callous triangle. As we know with cholecystectomies, you shouldn't define the junction with a cyst by the bile duct, and that should be avoided. But then in selected cases, the subtotal cholecystectomy really is important in this group of patients. So really what I hope I've been able to show you is why the early cholecystectomy is still probably preferred. When we do cholecystostomies, it's how we do it, transhepatically, I think, and when to remove the drain. The value of the endoscopic approaches, both of these have the same ability to resolve the acute cholecystitis. And today, the use of EUS certainly has an important contribution to make. Safe cholecystectomy should always be our objective in performing these operations, to prevent conversion, although that I've already mentioned is dependent on the skills in the area, but also the value of the subtotal cholecystectomy is, I think, an important contribution. So thank you very much.